picture this scenario for a second. You're a physical therapist or, an athletic trainer, maybe a sports medicine physician. It's Tuesday morning.
Oh, the classic Tuesday morning rush.
Right. You are staring down a fully booked schedule, and sitting right in front of you on the treatment table is a patient with a chronically painful osteoarthritic knee.
Or, maybe it's a computer programmer with just a relentlessly stubborn case of carpal tunnel syndrome.
Exactly. And you've been trained in dry needling. I mean, you spent your weekends at these continuing education seminars learning to systematically palpate the muscle, hunt for those top bands, identify the myofascial trigger points, and then, piston a needle in and out until you get that satisfying local twitch response.
Yeah, the whole search and destroy method. You find the knot, you stab the knot, you destroy the knot.
You destroy the knot. But then you run into this glaring clinical wall. You're palpating that osteoarthritic knee, and there are literally no obvious muscle knots to target in the joint line.
Or you find something in the programmer's forearm, you piston the needle, you get the twitch, but they come back 3 days later and their carpal tunnel pain is exactly the same.
Right. So what happens when the knot you're hunting is just, an illusion, or at least only a very tiny fraction of the actual neurophysiological truth?
It is just an incredibly frustrating moment for any clinician. And it is the exact point where that traditional search and destroy model of dry needling completely breaks down.
Because if we strictly adhere to that narrow definition of intramuscular manual therapy.
Which is exactly what is taught by some state boards and foundational courses, by the way.
Right. If we stick to that, we are actively choosing to ignore this massive, broader physiological reality. By focusing purely on the meat of the muscle belly, we're ignoring neural targets. We're completely bypassing connective tissue targets like, tendons and ligaments.
And ultimately, you are just leaving profound therapeutic benefits on the table for your patients.
So, welcome to the Deep Dive. Today, our mission is to completely reframe the clinical reasoning behind dry needling. We are stepping far beyond that narrow trigger point paradigm and adopting a really comprehensive tissue and neural approach.
Yeah, and our roadmap for this paradigm shift is a pivotal 2014 narrative review by James Dunning and his colleagues. It's titled Dry Needling, a literature review with implications for clinical practice guidelines.
It is such a foundational, arguably disruptive text. I mean, it challenges decades of dogma taught in clinical programs. We are going to look at the mechanisms, the research divide, the clinical application, and even the cellular science today.
But before we tear down the old house, we really need to look at the foundation.
Okay, let's unpack this. Let's start with first principles. Biologically speaking, what is actually happening when a clinician introduces a needle into human tissue?
Well, to understand the physiology, we first have to draw a hard line between the tools themselves, right? In standard Western biomedicine, we predominantly utilize what we call wet needling.
Wet needling, meaning a hypodermic hollow bore needle.
Exactly. The design of that needle is purely functional. It just acts as the delivery mechanism, a microscopic conduit, to introduce a pharmacological substance into the tissue.
So we're talking corticosteroids, anesthetics like lidocaine, sclerosins, or even botulinum toxins.
Right. The hollow bore needle is nothing more than the vehicle. The medicine does the heavy lifting.
Right. It's the delivery truck. The cargo is what actually matters.
That's a great way to put it. Dry needling, however, relies on a solid, highly flexible, thin monofilament needle. Functionally and physically, it is the exact same tool utilized in traditional acupuncture.
There is zero injectate, no pharmacological cargo at all.
None. Therefore, the needle itself is the primary intervention. It represents a very precise, localized mechanical stimulus introduced into a biological system. And the way we conceptualize that mechanical stimulus, it profoundly dictates how we treat our patients.
And we can really break this conceptualization down into 3 distinct layers of understanding, right? Let's walk through those layers. Because if I ask a first-year PT student what they are doing with that needle, I'm usually going to get a very mechanical, almost carpentry-based answer.
Oh, absolutely. You'll get the layer 1 explanation. This is the intuitive, almost primitive framework that has dominated the field for decades.
The idea that a myofascial trigger point is this tangible physical knot within the muscle belly.
Yeah, a taut band of chronically contracted sarcomeres. The layer 1 belief basically assumes that by physically stabbing the structural knot, we are mechanically disrupting the contracted fibers.
We're forcing the actin and myosin to decouple, allowing the muscle to finally relax.
Exactly. It views the body as a machine and the needle as a wedge. It's a purely local, purely structural perspective.
And honestly, it is incredibly seductive because it makes intuitive sense. The
Mm.
patient feels a hard bump, you press the bump, it hurts.
Mm.
You put a needle in the bump twitches and softens. It feels like direct causation.
It does. But as the Dunning Review points out so well, if we stop at layer 1, we are practicing with blinders on. We have to look at the layer 2 explanation.
Okay, so what is layer 2?
Layer 2 shifts our gaze from the gross muscular architecture to the intricate neural networks embedded within and around that muscle.
Ah, okay.
When a monofilament needle enters what we historically call a trigger point, it is not just untying a mechanical knot of protein fibers. It is physically interacting with, touching, and stimulating a dense constellation of tiny nerve endings.
Right. Researchers refer to these highly reactive areas as sensitive loci, don't they?
Yes, sensitive loci. They are nociceptors, motor end plates, and sympathetic nerve terminals that all aggregate into larger neurovascular bundles.
So the muscle is really just the surrounding real estate.
Hmm.
The actual target we are hitting is the physical endpoints of the peripheral nervous system.
Precisely. As Dunning highlights, and he cites the work of researchers like Hong here, the mechanical friction and irritation of the needle against these sensitive loci generates a massive overriding neural impulse.
So it introduces a novel, strong sensory input that travels up the afferent pathways to the spinal cord.
Right. Essentially interrupting that localized, vicious cycle of pain, ischemia, and sustained motor end plate activation.
Which perfectly tees up layer 3.
Yes.
This is the advanced research-level nuance that completely blew my mind when I was reviewing the source material. We really need to talk about the local twitch response, or the LTR.
Oh, the LTR. For
Yeah.
so many clinicians, the LTR is basically the holy grail.
Right. It's the physical validation. You piston the needle, the muscle visibly jumps under your hand, the patient winces, and you think, got it, I destroyed the knot.
But the Audette study completely subverts that entire narrative.
Yes. Let's unpack what Audette and his team actually did there, because it's wild.
It's a masterpiece in challenging clinical assumptions. They designed an experiment looking at patients with active, painful trigger points in their upper trapezius, the large muscle draping across the back of the neck and shoulder. The researchers inserted dry needles unilaterally, meaning they only needled the symptomatic targeted trigger point on one side of the body, let's just say the right shoulder.
Right, shoulder only. Got it.
But while they were doing this, they were recording electromyographic, or EMG, activity on the exact opposite side of the body.
And here's the paradigm-shattering finding. They recorded bilateral mirror image evoked motor unit potentials.
Exactly.
Wait, I want to make sure you, the listener, are really internalizing this. The clinician is standing on the right side of the table. They insert a needle into the patient's right trapezius, and the muscle in the left trapezius, which is entirely untouched by a needle, visibly twitches or registers an electrical spike.
Yes, the completely untouched contralateral side of the body responded with an efferent motor potential precisely when the needle was manipulated on the ipsilateral side.
Okay, let me play devil's advocate here. If the layer 1 intuitive theory is correct, if we are simply untying a localized mechanical knot of muscle fibers on the right side, the left side of the spine shouldn't care at all.
It shouldn't even know it's happening.
Right. If my car has a flat tire on the front right, patching it doesn't cause the front left tire to suddenly inflate.
Yeah.
But if I type a command on my keyboard in this room and a monitor in a different room flashes, I'm not just fixing a piece of plastic hardware. I am communicating with the motherboard.
That analogy is flawless. The Audette data proves that the local twitch response is not merely a peripheral, localized muscle spasm. It is a centrally mediated phenomenon.
Wow.
When you irritate that sensitive loci, the sensory nerve ending with the monofilament needle, you are sending a massive sensory barrage up the dorsal horn and right into the spinal cord.
And the spinal cord processes that input and fires a reflex motor response back down the alpha motor neurons.
And because of the way the spinal cord networks are wired, it fires that reflex bilaterally.
So when we hold that tiny 0.3 millimeter needle, we are essentially holding a stylus that allows us to write code directly to the central nervous system.
Yes, exactly. Audette concluded that this bilateral evoked potential argues strongly that myofascial pain syndrome involves a fundamental central nervous system abnormality, not just a peripheral muscle issue.
You are rebooting the spinal circuitry. You are using the muscular tissue merely as an access port, like a USB drive, to plug into the central nervous system.
That is a profound reframing. We are operators interfacing with the CNS.
But okay, if the physiological science is this advanced, if we know we are targeting neural tissue and inducing central spinal reflexes, Why is the clinical education and the legal definitions out there so intensely, almost exclusively, focused on intramuscular trigger points?
Well, that contradiction is the central thesis of the Dunning Review. It exposes what we can call the great literature divide.
Right, we have to look back at the political and regulatory environment around, what, 2012 and 2013?
Yes. During this period, massive professional organizations like the American Physical Therapy Association, along with several specific state boards, Mississippi, North Carolina, Louisiana, Nebraska, Colorado, they began releasing official regulatory position statements on dry needling.
And they defined it in a highly restrictive manner.
Extremely restrictive. They mandated that dry needling was an exclusively intramuscular procedure.
Meaning they codified into professional standards that you could only legally or ethically needle into the belly of a muscle, specifically hunting for myofascial trigger points.
Correct. They equated the entirety of the dry needling intervention with one highly specific technique, intramuscular manual therapy or trigger point dry needling. They effectively mandated the Layer 1 approach.
But looking at the source material, this political definition completely ignored the foundational literature of the practice itself.
It entirely disregarded it. The Dunning Review points directly to the origins of Western dry needling. The very first peer-reviewed journal article published on the topic by a Western biomedical physician was written by Dr. Carol Lewitt back in 1979.
Wow, 1979.
Yeah, he published a massive study examining the needle effect in 241 patients with various pain syndromes. And when you read his methodology, he absolutely did not limit his insertions to muscle tissue.
In fact, of the 14 target structures he identified in the study, only 2 of them were muscular trigger points.
Think about that. Only 2 out of 14.
That means roughly 85% of his targets had nothing to do with muscle knots. So where else was he putting the needles?
He was targeting ligaments, surgical scars, tendons, bone, periosteum, and tenoosseous insertion sites. He was systematically targeting the body's connective tissue network.
So Lewitt recognized in 1979 that the profound analgesic effect of inserting a needle without injectate occurred across a vast array of tissue types.
Exactly.
So if the godfather of Western dry needling was intentionally targeting ligaments and scars, why did the state boards in the 2010s suddenly restrict it to just muscle bellies?
Context is everything here. Physical therapists were, and honestly still are, fighting intense legislative scope of practice battles, primarily with acupuncture boards.
Ah, politics.
Yes. By compartmentalizing their needling practice as intramuscular manual therapy, and by hyper-focusing the nomenclature on the microscopic anatomy of a myofascial trigger point, the procedure sounded deeply biomedical, highly anatomical, and legally distinct from the meridian-based theories of acupuncture.
It was a defensive posture designed to survive a legislative hearing or a courtroom challenge.
Exactly.
Right.
But scientifically, biologically, it is an incredibly fragile position.
And that scientific fragility becomes glaringly obvious when we look at the reliability data. The Dunning paper exposes a massive, uncomfortable truth about the very foundation of the search and destroy trigger point model.
Yes, it really does.
I want to spend some time on the studies by Lucas, Liu, and Maibro, because if you are a clinician listening to this and you have ever sweated through a practical exam, terrified that your thumb wasn't on the exact right spot of the muscle, this is going to be incredibly validating for you.
It is the critical flaw of the IMT paradigm. The entire concept of trigger point dry needling rests on a single massive assumption that a human clinician can manually palpate a patient's skin, dig through the adipose tissue, and find the exact microscopic epicenter of a contracted nodule within a taut band of muscle, and then accurately spear it with a hair-thin needle.
Right.
But rigorous scientific investigation has shown that manual palpation for identifying the precise location of a trigger point has shockingly poor inter-examiner reliability.
Let's clearly define inter-examiner reliability for this specific context, just so we understand the gravity of these studies.
Sure, it is a measure of diagnostic consistency. If I am an expert clinician and I examine a patient's upper trapezius, find what I believe is the active trigger point and mark it with an invisible UV pen.
Okay.
Then you walk into the room entirely blinded to my assessment. You examine the exact same patient, palpate the exact same muscle, and mark your own spot. The question is, do our marks overlap?
And what did the actual numbers show?
The numbers are dismal. Liu and colleagues published a study demonstrating that expert inter-examiner agreement on the location of a trigger point was only 21%.
21%. That is not slightly off. That is essentially random chance.
It gets worse, actually. Shiati et al. conducted a study looking at the margin of error among examiners trying to pinpoint trigger points in the upper trapezius. They reported spatial error rates ranging from 3.3 to 6.6 centimeters.
Wait, up to 6.6 centimeters. That is over 2.5 inches.
Yeah.
If my target is a microscopic neuromuscular junction and I am off by over 2 inches, I am practically in a different zip code, anatomically speaking.
Exactly. Lucas et al. Performed a comprehensive systematic review of the literature and concluded unequivocally that there is no high-quality data supporting the reliability of pinpointing the exact localized epicenter of an active trigger point.
Wow.
Clinicians are fairly good at agreeing if a muscle, broadly speaking, is tender or hyperalgesic, but they cannot reliably agree on the physical location of the actual nodule.
Look, let me channel the immediate defense of a seasoned manual therapist right now. If I'm listening to this and I've been needling for 10 years, I'm screaming at my phone, those examiners in the study just have bad hands. I know what I'm feeling. I feel the taut band. I feel the twitch when I hit it.
Right, that's the natural reaction.
If the reliability is only 21%, how does the Dunning paper explain the fact that we still get results? If we aren't accurately hitting the target, why do the patients get better?
That is the exact question that forces the paradigm shift. If you cannot reliably find the precise epicenter of the physical knot, you cannot reliably claim your success is due to deactivating it via the exact structural destruction model of Travel and Simons.
It forces us to accept layer 2 and layer 3.
Yes. When we insert a needle, miss the actual knot by 3 centimeters, but the patient still gets profound pain relief, why did it work? Because we didn't need to spear a physical protein knot. We stimulated the vast regional neurovascular network.
We interacted with the sensitive loci that are densely packed throughout that entire 6-centimeter radius. We induced the spinal reflex.
Exactly. Which means the magic isn't in sniper-like micromillimeter precision. The magic is the needle entering and altering the bioelectrical and neurochemical field of the tissue itself.
And this realization directly exposes another major critique leveled by the Dunning Review, doesn't it? The intentional, systematic exclusion of the acupuncture data set by Western physical therapists and their regulatory boards.
Oh, this is the elephant in the room, the absolute siloing of information.
The defensive posture of, we do dry needling, which is science. We don't do acupuncture, which is energy work.
It is a massive intellectual blind spot. Let's just look at the etymology. The word acupuncture literally translates to needle penetration. Acu means needle. Puncture means penetrate. Simple as that. Now, it is absolutely true that traditional Chinese medicine utilizes these needles based on pre-scientific theories of meridians, qi, and energetic balancing. But what the physical therapy community largely ignores is that for the past 40 years, Western biomedical researchers have been conducting massive, highly rigorous, randomized controlled trials using those exact same dry monofilament needles.
And they are using them without injectate to treat strictly Western allopathic medical diagnoses.
Precisely. We are talking about major structural pathologies, radiographically confirmed knee osteoarthritis, MRI-confirmed plantar fasciitis, EMG-verified carpal tunnel syndrome.
The researchers running these RCTs aren't measuring the flow of qi. They are measuring Western objective markers, pain scales, joint space narrowing, nerve conduction velocities, inflammatory cytokine levels.
And these trials are being published in the most prestigious medical journals on the planet. The Annals of Internal Medicine, the British Medical Journal, the Cochrane Database of Systematic Reviews.
The methodology is ironclad.
It really is. But because the title of the study happens to include the word acupuncture, many physical therapy boards and clinicians simply throw the data in the trash.
Because acknowledging it shatters the political definition that needling must be strictly intramuscular. I mean, if a Cochrane review shows a needle in the wrist ligaments fixes carpal tunnel, it proves the IMT definition is incomplete.
Exactly. And Dunning argues passionately against this hypocrisy. He points out that physical therapists do not ignore high-quality research on spinal manipulation just because the paper was published by an osteopath or a chiropractor.
Right.
The mechanical procedure of inserting a monofilament needle into human connective tissue is shared across multiple professions. By intentionally ignoring the Western biomedical acupuncture literature, clinicians are actively depriving themselves of the strongest, highest-level evidence available for treating a massive variety of neuromusculoskeletal conditions.
Okay, this is the perfect pivot point. We have successfully deconstructed the old paradigm. We've torn down the layer 1 idea of just stabbing protein knots, we've exposed the reliability crisis of manual palpation, and we've bridged the artificial gap between Western dry needling and the biomedical acupuncture literature.
So now we build the new paradigm.
Exactly. What does this all mean for you, the listener, when you walk into your clinic tomorrow morning? How does this massive shift in neurophysiological understanding translate into actionable, step-by-step clinical changes? Let's start with assessment.
The first and arguably most difficult change you need to make tomorrow is psychological. You must relieve yourself of the diagnostic anxiety of finding the perfect muscular trigger point.
Just let it go.
Yes, you should absolutely still palpate the tissue. You are still looking for areas of regional hyperalgesia, taut bands, tissue density changes, and general tenderness. But you must let go of the stressful illusion that your treatment will fail if you don't find a microscopic 2-millimeter nodule.
Because if the published experts are off by up to 6 centimeters, you are just stressing yourself out over a ghost.
Precisely. Palpate to understand the region, not to find an exact coordinate. Second, you must drastically expand your anatomical assessment. Stop looking exclusively at the muscle belly.
So when a patient presents with a pathology, ask yourself, what are the perineural targets in this area? What is the state of the surrounding connective tissue?
Are there ligaments that refer pain to this zone? Are there tenoosseous junctions? Is there a thick band of surgical scar tissue that might be tethering the fascia and creating an ischemic environment?
Your assessment map needs to upgrade from a simple muscle chart to a comprehensive 3D topographical map of the entire neuromusculoskeletal landscape.
That makes total sense.
We assess the whole system. But what about the intervention itself? Because this is where I think some egos are going to get bruised as we were talking about the end of the pure pistoning era.
We are. The fast-in, fast-out sparrow-pecking or pistoning technique is ubiquitous. This is where the clinician repeatedly and rapidly thrusts the needle in and out of the tissue to elicit multiple local twitch responses and then immediately withdraws the needle and moves on.
Let's be honest. It is what looks incredibly cool on an Instagram reel. The needle goes in, the muscle violently jumps, the patient grimaces, and it looks to the observer like the clinician is powerfully fixing something right in front of your eyes.
It is highly performative, and it provides immediate, highly visible tactile feedback to the clinician. And to be fair to the technique, the literature does indicate that it can provide immediate short-term pain relief. However, Dunning's review makes a stark, undeniable point based on the hierarchy of evidence. There are virtually no high-quality, long-term randomized controlled trials that support exclusive in-and-out pistoning at muscular trigger points for chronic pain resolution.
So if your goal is long-lasting structural and neurological tissue change, the practice of immediately removing the needle after pricking a trigger point must be deeply questioned.
Yeah.
So if we aren't just pistoning for 30 seconds and tossing the needle in the sharps container, what is the alternative? What is the technical shift?
The shift is embracing the in situ methodology. When you evaluate the vast majority of the highly successful, large-scale randomized controlled trials, the studies proving long-term, durable efficacy for massive public health burdens like chronic low back pain, neck pain, and osteoarthritis, they utilize a fundamentally different technique.
They insert the needle, manually manipulate it to elicit what is documented as a Decky response, and then they leave the needle alone.
Yes.
Let's hover on that concept, the Decky response. We're shifting away from the sharp, violent electrical twitch of the LTR. Practically speaking, how does the Decky response present, and what is happening biologically when we achieve it?
Decky is a constellation of sensory inputs. Clinically, the patient describes it not as a sharp shock, but as a profound, deep, dull ache.
They might describe a sensation of heaviness in the limb, distension, numbness, or a spreading feeling of pressure and warmth radiating from the needle site.
Biologically, while the fast twitch of an LTR primarily activates the myelinated A delta fibers, the Decky sensation is heavily associated with the activation of the unmyelinated, slower C fibers.
It is a profound, deep tissue sensory activation that strongly signals the brainstem and hypothalamus.
Exactly. And once you manually stimulate the needle to achieve that specific sensory threshold, the crucial next step is to leave the needle in situ.
You leave it in the tissue. For how long?
The highest quality literature strongly supports leaving multiple needles in place for anywhere between 10 and 30 minutes.
Okay, I have to stop you there because as a clinician, you just set off absolute alarm bells in my scheduling software.
Oh, I know.
If I'm shifting from a 2-minute pistoning add-on at the end of a manual session to a 30-minute in-situ retention time, how does that even work in a high-volume outpatient orthopedics clinic where I'm seeing a patient every 15 to 20 minutes? You are asking for a massive operational change.
I am, and it is a major friction point between the biological reality of tissue healing and the administrative reality of modern healthcare. But we have to follow the physiology, not the clinic schedule.
A massive Cochrane review analyzing treatments for chronic low back pain concluded unequivocally that needle retention for about 10 minutes is significantly more effective than removal immediately after insertion.
High-quality trials treating carpal tunnel syndrome leave the needles in for 30, sometimes up to 60 minutes.
Mm.
Plantar fasciitis trials standardly use 15 to 20 minutes. Knee osteoarthritis trials consistently utilize 20 to 30-minute retention times.
Why does the body demand that time?
Because you are initiating a complex neuroendocrine and biomechanical cascade, you are creating a controlled microlesion, you are signaling for local vasodilation to call blood flow to an ischemic area.
You are triggering the release of endogenous opioids and altering gene expression in the connective tissue.
It literally takes time for the body's chemistry to manufacture and deliver those responses to the mechanical signal. You have to give the tissue time under tension. You have to slow down, leave the interface open, and let the central nervous system process the data you just inputted.
That makes total sense. Biology cannot be rushed by a billing code. Now, what is the second major intervention shift we need to make alongside the longer retention times?
We must aggressively embrace progression and regional interdependence.
Regional interdependence. That's a classic PT concept. Let's define it clearly for anyone rusty on the theory.
Regional interdependence is the clinical concept that primary impairments in a remote, completely different anatomical region may be the underlying driver of the patient's primary localized complaint.
Physical therapists use this logic every single day in joint manipulation and exercise prescription. If a patient comes into the clinic with anterior shoulder pain or subacromial impingement, an expert manual therapist won't just rub the shoulder.
No, they will frequently perform a thrust manipulation on the thoracic spine or the cervicothoracic junction. They are treating a proximal spinal structure to neurologically and biomechanically affect a distal symptom in the arm.
If a patient has lateral epicondylalgia or tennis elbow, we manipulate their cervical spine.
Right, because we understand the body is an intimately connected kinetic, fascial, and neurological chain. We never treat a joint in isolation.
Exactly. But for some bizarre reason, the moment many clinicians pick up a dry needle, they suddenly develop extreme tunnel vision. They abandon all their training in regional interdependence, and they exclusively needle the exact square inch of tissue that hurts. They chase the pain locally.
The political definitions made it worse, too. Some state boards literally forbade clinicians from needling distal points because they feared it mimicked meridian therapy.
But the biomedical evidence firmly, heavily supports the absolute necessity of both proximal and distal needling. We have to treat the systemic neurological chain, not just the local symptom.
We really do.
Okay, let's take all of this theory. The in situ retention, the A delta versus C fiber activation, the regional interdependence, and let's make it intensely practical. Let's move into some case-based reasoning. I'm going to present a couple of standard patient scenarios, and I want you to walk the listener through the exact clinical thinking using this new expanded Dunning paradigm.
Let's do it.
Case number 1. You have a 65-year-old patient. They have radiographically confirmed osteoarthritis in the right knee, joint space narrowing, osteophyte formation. They complain of a deep, relentless, aching joint pain that worsens with weight bearing.
Okay.
If I am an old school, strictly IM key trained therapist, I might poke around their quadriceps, maybe hunt for a trigger point in the vastus medialis, piston it a few times to release the tension on the patella, and call it a day. But what does the comprehensively trained, Dunning-informed clinician do?
Well, the informed clinician looks at the massive body of evidence. They look at the huge meta-analyses published by Vickers, Mannheimer, and Witt. These are studies involving thousands of patients that demonstrate profound, long-lasting efficacy for needling osteoarthritic knees.
And here's the paradigm shift. In those highly successful trials, the researchers are absolutely not hunting for muscular trigger points in the quad. They are systematically applying periarticular non-trigger point needling.
Periarticular, meaning they are placing the needles directly around and into the joint capsule itself.
Exactly. You are inserting needles into the dense connective tissue, the collateral ligaments, the joint line, the coronary ligaments, and the intercapsular spaces.
But wait, let's connect this back to layer 1. If there is no muscle tissue there is no actin and myosin, there is no physical knot to release. Why on earth does sticking a needle into a ligament reduce the pain of bone-on-bone osteoarthritis?
Because you are initiating a powerful cascade of physiological changes that completely alter the environment of the joint. First, we look at hemodynamics.
Right, blood flow.
Studies utilizing laser Doppler flowmetry, which literally measures real-time blood perfusion in tissue, demonstrate that needling these specific non-trigger point locations around the knee significantly increases local microcirculation.
An osteoarthritic joint is a hypoxic, stagnant swamp of inflammatory mediators, cytokines, substance P, bradykinin.
By inserting the needles periarticularly, you cause massive vasodilation. You are flushing out that inflammatory swamp and bringing in fresh, oxygenated blood.
You are literally restoring the microplumbing of the knee.
Yes. Second, there are profound endocrinological changes. Robust trials have shown that applying electrical dry needling to these periarticular connective tissues results in measurable systemic increases in beta endorphins, which are the body's intensely powerful natural painkillers.
Simultaneously, the intervention causes a systemic decrease in cortisol, which is a primary stress and inflammatory hormone.
So you aren't just changing the mechanics, you are literally altering the chemical bath that the joint sits in.
Precisely. You are stimulating the sensitive loci embedded in the joint capsule's connective tissue. This sends a massive signal to the central nervous system, which in turn alters the biochemical and neuroendocrine milieu of the joint.
In clinic, you would insert multiple needles circumferentially around the joint line, manually manipulate them to elicit that deep, heavy dicky sensation, and then you leave them in situ for 20 to 30 minutes while the vascular and endocrine systems do their work.
That is the evidence-based way to treat knee OA with a needle.
Incredible. It shifts you from being a mechanic to being a bioelectrician. Let's look at case number 2. A 40-year-old patient with mild to moderate carpal tunnel syndrome. They have tingling, numbness, and sharp pain radiating into the median nerve distribution of the hand. They're waking up at night shaking their wrist.
A very common presentation.
Again, the old school approach.
Yeah.
Maybe I hunt for a trigger point in their forearm flexor bellies, hoping to release the pull in the wrist. What is the new school approach?
The new school entirely bypasses the muscle and applies direct perineural needling. We are targeting the nervous tissue itself, or more specifically, the connective tissue sheath immediately surrounding the median nerve.
Wait, I can hear the gasps from the audience. We're intentionally putting needles right next to the median nerve. We spend our entire anatomy education learning how to avoid nerves.
It requires high-level anatomical knowledge, precision, and confidence, yes. But studies by Khosrawi, Yang, and others have definitively shown that inserting dry needles in the immediate vicinity of peripheral nerves and neurovascular bundles in the wrist and forearm is highly effective and safe when performed correctly.
But what is the mechanism? If the nerve is compressed under the transverse carpal ligament, putting a tiny needle near it doesn't mechanically cut the ligament or unpinch the nerve. So how does it stop the numbness?
It doesn't mechanically unpinch it, no. The magic is in the microvasculature. By needling adjacent to the nerve, you aggressively stimulate local microcirculation within the vasa nervarum.
The vasa nervarum, the microscopic blood vessels that actually feed the nerve cable itself.
Exactly. Carpal tunnel syndrome, at its core, is a pathology of ischemia. The compression squeezes the vasa nervarum, cutting off blood supply to the nerve. The nerve essentially begins to suffocate, which causes the tingling and pain.
The mechanical stimulus of the perineural needling causes profound local vasodilation. You force blood back into the suffocating nerve.
Furthermore, these RCTs show that this perineural needling actually improves sensory and motor nerve conduction velocities on EMG testing. You are biologically helping the nerve heal its ability to transmit electrical signals by rapidly improving its local metabolic environment.
And again, to allow that metabolic shift, we're leaving the needles in.
Yes. The successful carpal tunnel trials frequently left the needles in situ for 30 to 60 minutes.
It is a completely different ballgame.
Yeah.
You aren't treating a tight muscle. You are actively rehabilitating a peripheral nerve's blood supply.
Precisely. And this highlights perfectly why adhering strictly to the intramuscular manual therapy definition is so tragically limiting. You simply cannot effectively treat carpal tunnel syndrome with a needle if you are legally or dogmatically terrified to place a needle near a nerve.
Okay, this is where the conversation gets critically important. We've talked extensively about what to do and how the mechanisms work. Let's shine a light on the common errors, the clinical pitfalls, and the misconceptions that constantly trap well-meaning clinicians.
Because even when people try to adopt this new expanded paradigm, they inevitably carry over old historical baggage.
What is the first major mistake you see out there?
Mistake number 1 is what we can label the silo effect. It is the deeply ingrained, mistaken belief that if a clinician is performing Western dry needling, it must look entirely different, both functionally and procedurally, from Western biomedical acupuncture.
Right. It's the psychological need to feel professionally distinct. The clinician says, I am a doctor of physical therapy. I went to a medical program. I don't do acupuncture. Therefore, my needling technique must look violent and mechanical so no one confuses it with energy work.
It is an ego-driven or sometimes a legally driven distinction. It is not a physiological one. The Dunning Review is extremely clear on this. Inserting a filiform needle into human tissue without injectate is a shared universal procedure across multiple healthcare professions.
Think about spinal manipulation. An MD, a DO, a PT, and a chiropractor might all utilize a high-velocity, low-amplitude thrust manipulation on the lumbar spine.
Now, their theoretical construct might differ wildly. An osteopath might diagnose a somatic dysfunction, a chiropractor might treat a subluxation, while a PT might assess a facet joint restriction, but the physical-mechanical intervention delivered to the patient's spine is largely identical.
To pretend that a piece of surgical steel knows the specific letters printed on the clinician's badge is scientifically absurd. The human body responds to the mechanical stimulus of the needle, period. Our job is to use the best evidence available, regardless of the silo it was published in.
I love that. The needle doesn't know your degree.
Let's move to mistake number 2.
Yeah.
This loops back to our discussion on regional interdependence. The lingering misconception that distal needling is just Eastern medicine mysticism.
Oh, yeah.
I know we mentioned that some state regulatory boards actually banned PTs from needling distal points because they assumed it was just an attempt to manipulate Keys along a traditional meridian.
Yes, and that ban demonstrates a profound, almost embarrassing lack of modern neurophysiological understanding. The Dunning paper highlights a brilliant and frankly astonishing study by Shea and his team using an animal model, specifically a rabbit model, that completely scientifically debunks this misconception.
The rabbit study. You have to dive deep into this. Walk me through the exact methodology, because if we are claiming that sticking a needle into a patient's calf can medically shut down a muscle spasm in their hamstring via the spinal cord, I need to hear the receipts.
It is a phenomenal piece of literature. Shea and his team were investigating the irritability of myofascial trigger spots in the biceps femoris. That is the large proximal hamstring muscle in the upper leg of the rabbit.
Okay.
Using specialized EMG equipment, they continuously measured the spontaneous electrical activity, essentially the baseline end plate noise, in that highly irritable proximal muscle. It was firing constantly.
Okay, so we have a documented angry, spasming upper leg muscle hooked up to a monitor.
Next, they performed dry needling intervention on the distal gastrocnemius muscle, that is the calf muscle, located much further down the leg, physically disconnected from the hamstring.
And what happened on the EMG monitor to the angry upper leg?
The moment the distal needling commenced, the spontaneous electrical activity in the proximal hamstring trigger point was massively suppressed. Inserting a needle lower down the leg functionally shut off the pain and spasm signals higher up the leg.
Now, let me play devil's advocate again. How do the researchers know that wasn't just a local fascial tug? Maybe pulling the connective tissue in the calf mechanically yanked on the fascia of the hamstring, and that mechanical stretch caused the relaxation. How do we definitively know it was a central nervous system response?
Because the researchers anticipated that exact critique, which leads to the second phase of the experiment. After establishing the distal effect, they surgically transected the spinal cord of the rabbits at the L5-L6 level.
They completely severed the communication cable to the brain.
Exactly. The physical fascial connections were entirely intact, but the neurological highway to the brainstem was cut. They then repeated the exact same experiment. They needled the distal calf, and this time, absolutely nothing happened. The suppressive remote effect in the hamstring completely vanished. The EMG kept firing.
Wow, that is undeniable proof.
It proves, without a shadow of a doubt, that the remote effects of distal dry needling are mediated entirely by the central nervous system. Specifically, it is related to the activation of the diffuse noxious inhibitory control system, or DNIC.
DNIC. That is a massive concept in pain science. Let's break down the physiology of DNIC for the listener.
DNIC is a powerful central pain inhibitory mechanism hardwired into our neuroanatomy. The concept is often simplified as pain inhibits pain.
Essentially, when you introduce a noxious stimulus like a sharp needle prick or the deep ache of Deccia into one part of the body, that sensory signal travels all the way up the spinal cord to the brainstem, specifically targeting the subnucleus reticularis dorsalis in the medulla.
Right.
The brainstem receives the pain signal from the calf, What does it do with it?
The brainstem processes that novel threat and immediately sends widespread descending inhibitory signals back down the spinal cord. These inhibitory signals suppress nociceptive or pain inputs originating from completely different areas of the body.
So by needling the distal calf, the researchers triggered the rabbit's brainstem to unleash a flood of descending inhibition that chemically shut down the irritability in the hamstring.
Yes. So when a physical therapist utilizes a distal point, when they needle a patient's hand to relieve a throbbing pain in their neck or shoulder, they are not practicing ancient mysticism.
They are explicitly biologically hacking the Western evidence-based neurophysiology of the DNIC system and descending spinal reflexes.
Precisely. And to legally rule out the use of distal points out of a misguided fear of looking Eastern actively deprives the patient of one of the most powerful, centrally mediated analgesic tools we possess.
That is a staggering realization. All right, let's look at mistake number 3. And this one is incredibly prevalent in the sports medicine and orthopedic communities. It is the misconception that tendinopathy is purely a biomechanical load or muscle tension issue, and therefore, needling should only be directed at the muscle belly located above the diseased tendon.
This is a massive area of clinical underutilization.
Okay.
Clinicians will see a patient with chronic Achilles tendinopathy or a nasty patellar tendinosis. Their clinical reasoning says, the calf muscle is tight, it's pulling on the Achilles, so I will needle the soleus to release the tension.
That logic is fine as far as it goes, but they completely ignore the diseased tendon itself. The literature overwhelmingly supports needling the dense connective tissue of the tendon directly.
But wait, let's go back to our tissue definitions. A tendon is connective tissue. It doesn't have actin and myosin. It doesn't have myofascial trigger points to twitch. What does stabbing an actual tendon physically achieve?
To understand that, we have to understand the pathology. Chronic tendinopathy is fundamentally characterized by a failed, stalled healing response.
It is a highly hypoxic environment, meaning it chronically lacks adequate oxygen, and it possesses notoriously poor blood flow. It is locked in a state of degenerative tendon disrepair.
Needling the tendon directly, or specifically targeting the interface between the tendon and its surrounding sheath, causes an immediate massive local vasodilation.
You are intentionally causing microtrauma to force blood into a biological dead zone.
Exactly. Studies by Kubo and colleagues utilize advanced imaging to show statistically significant, undeniable increases in local blood flow and oxygen saturation levels directly inside and around the Achilles tendon following dry needling interventions.
Furthermore, research by Lee and Langevin demonstrated that the physical mechanical trauma of the needle penetration actively stimulates collagen proliferation and accelerates fibroblastic activity.
You are essentially using the needle to manually restart the local inflammatory and healing cascade that the body had given up on. You are calling the construction workers back to the site and providing them with fresh, raw materials.
So the takeaway for the sports med clinician listening right now is if you have a chronic Achilles or patellar tendon patient, do not just needle the muscle belly and walk away. Get into the peritendinous space. Needling is a connective tissue intervention.
Exactly. Connective tissue is a primary, highly reactive, profoundly important target. Let's move into a really fascinating area of this discussion, advanced insights and controversies. We have danced around this political and historical divide, but let's hit the trigger point versus acupoint overlap directly.
Yes.
Because this is the exact intersection where two massive, seemingly opposing historical paradigms crash into each other. What did the Dorscher study actually investigate, and what did they find?
This is arguably one of the most fascinating pieces of data synthesis in the entire medical literature. Peter Dorscher, a medical physician, conducted an incredibly rigorous anatomical and clinical cross-analysis. He started with the 255 common myofascial trigger points that were exhaustively mapped out by Travel and Simons in their famous manuals, which is essentially the foundational Bible of Western trigger point therapy.
Right.
He took those 255 specific Western anatomical coordinates and compared them directly to the classical acupuncture points that were mapped out thousands of years ago in Eastern texts.
And what was the degree of overlap between these two completely separate systems?
He found that an astonishing 93.3% of the common myofascial trigger points anatomically corresponded perfectly, spot for spot, with classical acupuncture points.
Over 93%. They're pointing at the exact same millimeter of real estate on the human body.
It goes even deeper than just anatomical location. Dorscher also compared the clinical indications. When he mapped the Western empirical pain referral patterns for those specific trigger points, they matched the ancient meridian pain distributions described in the Chinese texts up to 97% of the time.
Wait, really think about the magnitude of that. A Western medical doctor in 1980 systematically presses on a knot in a patient's shoulder and notes, when I press here, pain predictably shoots down the lateral side of the arm.
And a Chinese text written 2,000 years prior dictates, if you insert a needle into this specific point on the shoulder, it will clear the channel down the lateral side of the arm.
Exactly. As the pioneering pain researcher Ronald Melzack noted way back in 1977, what we're looking at is two entirely different philosophical frameworks observing and documenting the exact same underlying neurophysiological phenomenon.
The ancient practitioners mapped out these high-density neurovascular bundles and, using the language of their era, called them acupoints. Modern Western medicine mapped out the exact same sensitive loci, using the language of biomedicine, and called them trigger points.
The nomenclature is different. The anatomy is identical.
That is deeply humbling. And honestly, it should put the ego of the modern evidence-based clinician in check. We did not invent this map. We simply applied a different vocabulary to it.
Let's pivot from the historical to the microscopic. I want to talk about the cellular level insight. You mentioned Helene Langevin's research earlier when we were talking about tendons.
Yeah.
How exactly does the gross mechanical insertion of a steel needle alter the behavior of an individual cell? Because again, we are not injecting chemical messengers. We are just putting a piece of inert metal into the body.
This brings us into the cutting-edge field of mechanotransduction. Helene Langevin's research at Harvard and the University of Vermont is absolutely groundbreaking in this regard. She specifically investigated the properties of subcutaneous connective tissue. She observed that when you insert a monofilament needle into the tissue and manually rotate it or manipulate it, the collagen fibers of the connective tissue literally wind around the shaft of the needle.
So mechanically, it's like twisting a fork in a bowl of spaghetti. The tissue physically spools around the metal.
That is the perfect visual. Now, imagine what happens at the cellular level when that spooning occurs. Connective tissue is packed with fibroblasts, which are the cells responsible for producing collagen and maintaining the extracellular matrix.
These fibroblasts are physically tethered to the extracellular matrix via transmembrane proteins called integrins.
When the clinician winds the tissue around the needle, it creates a physical, mechanical stretch on the matrix. That tension pulls on the integrins, which in turn physically pulls on the actin cytoskeleton inside the fibroblasts.
You are physically deforming the structure of the cell.
Yes. Langevin proved that this mechanical signaling induces rapid dynamic cytoskeletal remodeling within the fibroblasts. The cell physically changes shape, spreading out within the tissue.
And here is the magic of mechanotransduction. That physical deformation of the cytoskeleton triggers a massive biochemical signaling cascade inside the cell. It activates Rho-GT paces, alters ATP release, and fundamentally changes the cell's gene expression and chemical output.
Let me make sure I'm grasping the scale of this. By twisting a 0.3 millimeter needle with my fingers, I am physically pulling the scaffolding of a cell so hard that its actual DNA changes what it is manufacturing.
Yes, you are dictating cellular behavior through mechanical force. The downstream effects of this altered gene expression include reducing local tissue stiffness, resolving chronic inflammation, and initiating tissue repair.
You are physically pulling on the biological scaffolding to force a healing response. This proves conclusively at a cellular level that the profound effects of dry needling are mechanotransductive, they are heavily connective tissue-based, and they absolutely do not require the presence of a muscular trigger point to be effective.
Connective tissue responds dynamically, intelligently, and chemically to the needle.
That is mind-bending science, and it gives us the ultimate HOW.
Let's look at one last piece of hard data before we wrap up the microcirculation metrics. You touched on this with the NEOA discussion, but let's give the listener the raw numbers to really cement this concept.
We can look at highly specific laser Doppler flowmetry data, which is the gold standard for measuring local blood perfusion. In a key study examining the effects of needle electrical intramuscular stimulation placed directly above a myofascial trigger point, researchers measured the blood perfusion units, or BPUs.
Before the needling intervention, the ischemic, highly painful tissue registered at 127.3 BPUs. Following the needling intervention, the local microcirculation surged to 310.2 BPUs.
That is substantially more than a twofold increase in local blood flow.
It is a massive, instantaneous vascular flush. When you consider that localized ischemia, low blood flow, is highly correlated with pain intensity, lower tissue pH, and the accumulation of inflammatory mediators in myofascial syndromes, you realize that needling is not just a neuromuscular trick.
It is a profound vascular intervention. You are forcibly restoring the microplumbing in the tissue, washing out the pain chemicals, and restoring metabolic homeostasis.
All right, this has been an incredibly dense, undeniably paradigm-shifting exploration. Let's distill all of this complex physiology, history, and literature down for you, the listener. You have absorbed this masterclass. You are walking into the clinic right now. What are the high-yield, uncompromising takeaways you need to integrate into your practice today? Give me the synthesized clinical framework.
Here are the core actionable takeaways based on the Dunning Literature Review and the broader physiological science. Number 1, broaden your targets instantly. Dry needling is a systemic intervention that targets neural tissues, sensitive loci, and dense connective tissues like ligaments, joint capsules, and tendons. Do not limit yourself exclusively to muscle bellies and trigger points.
Point well taken. What's next?
Number 2, relieve your diagnostic anxiety immediately. Do not rely solely on manual palpation to pinpoint the exact micromillimeter center of a trigger point. The inter-examiner reliability data proves it is a flawed pursuit. Instead, focus on identifying areas of regional hyperalgesia, systemic tissue tension, and neurovascular density.
Love that.
Number 3, embrace the broader literature without bias. Do not ignore high-quality Western biomedical acupuncture randomized controlled trials just because of political terminology. They use the exact same needles to treat the exact same Western diagnoses. Integrate their brilliant findings into your evidence-based practice.
A needle doesn't know your degree.
Exactly. Number 4, shift your dosage and respect the biology. The era of exclusive, hyperfast in and out pistoning is over. Consider the immense value of leaving multiple needles in situ for 10 to 30 minutes after eliciting a deep DECU response. Give the central nervous system and the cellular mechanotransduction time to actually work.
Biology cannot be rushed.
Number 5, utilize the power of regional interdependence. Needling distal and proximal to the primary pain site, even utilizing the contralateral side of the body, is heavily backed by solid neurophysiological evidence, specifically the DNIC system and spinal cord reflexes. Stop chasing the local pain exclusively.
And the final takeaway.
Number 6, expand your clinical indications. For massive public health burdens like knee osteoarthritis, carpal tunnel syndrome, and chronic tendinopathy, periarticular and perineural non-trigger point needling should be considered a primary frontline intervention, not a last resort.
That is a brilliant, actionable synthesis. You are no longer just a biological mechanic hunting for a frayed knot in a rope.
Yeah.
You are a neuroelectrician interfacing with the vast interconnected network of the human nervous system. Listener, I want to deeply thank you for joining us on this deep dive. If you absorb the mechanics, the cellular biology, and the clinical reasoning we explored today, you have significantly leveled up your capacity to heal your patients.
It truly is a profound shift in clinical perspective.
Before we sign off, I want to leave you with one final provocative thought to mull over on your own time, something that builds on everything we've talked about today regarding the sheer power of the nervous system.
Consider this. If simply inserting a tiny, sterile 0.3 millimeter filament into the distal skin and connective tissue of a patient's calf can send a signal traveling up the spinal cord, alter central nervous system processing in the brainstem, and completely shut down a violently painful muscle spasm on the exact opposite side of their body, what does that mean for how we conceptualize the power of human touch in any manual therapy we apply to the surface of the human body?
Whether it's high-velocity spinal manipulation, a gentle fascial mobilization, or just a reassuring hand placed warmly on a frightened patient's shoulder.
Are we ever just treating a local mechanical muscle? Or are we, in every single physical interaction, hacking into the infinite complexity of the nervous system?
Think deeply about that the next time you put your hands on a patient. And remember, when you look out at that complex diagnostic landscape and the clean binary X-ray machine is broken, the murky, muddy waters aren't something to fear. They are the entire bioelectrical ocean you get the privilege of working in. See you next time on The Deep Dive.